from providing the health needs of the Ethiopians, we now are fortunate enough to focus our attention on the Indigenous community of Australia. I think it's a most fitting way to end the day with a focus on Indigenous health when we started our day with the Welcome to Country by Uncle Alan Madden. Our final speaker for the day was born in Nambour in Queensland and studied secondary and tertiary education in Brisbane, and now works and lives in Mount Isa and worked and lived in Mount Isa after graduating from university. She is now the Senior Service Development Manager for the Institute for Urban Indigenous Health in southeast Queensland. She lists as her achievements achieving her nursing degree. And just having a quick word with Renee a little earlier, she said her other achievement is actually delivering her first keynote address ever. So when you look around a large room like this, filled with lots and lots of people, it can be a daunting affair, and I acknowledge and give you credit for the fact that you've had the courage to stand up here today and deliver your message. Renee played elite sport and in fact represented her state not in one, not in two, but in three different disciplines. In netball, basketball and softball, she has performed at one of the most elite levels in Australia. Her loves certainly include her family. It includes softball as a passion and also Jerry Seinfeld, I'm pleased to note. She said, I'm known for doing rather than saying things, so I guess I could be classified as a doer. To have the courage today and to commit to delivering her message to us all, I think is representative of the fact that you are indeed a doer. Which clearly she must be, because not only is she a wife, she also has 3 children to tend to as well. So to share with us how we can make a difference in Aboriginal primary health care, we're going to be taking on a very practical insight on how to deliver the very best care possible to one of Australia's most vulnerable populations. Could we please give an extraordinarily powerful welcome, ladies and gentlemen, Renee Blackman.
Ooh, technology. Here we go. Okay, thank you very much for your welcome, and thank you for having me here today. It was great. Before I do my traditional acknowledgement, because that's part of my culture, that's what I have to do, I just want to say thank you, Lucy. One of the things that stood out to me today from your speech was when you said, understand the other before you judge it. It's very much what happens with us. So thank you very much for that. And thank you to you, your organisation and Dr. Hamlin. I think you do wonderful work. Thank you. So I'm a proud Gubbi Gubbi woman from the Sunshine Coast, Nambour, as you heard. I don't know whether anyone knows the big pineapple, but that's where I'm from. I'd like to acknowledge Uncle Alan this morning and his traditional elders, past and present, from the land of Sydney. And also acknowledge some of the speakers I heard today. I thought when they offered me the opportunity to actually speak today, and it was, it's leading change, and I think that's what we do in the southeast corner at the moment. I think we do some pretty innovative things in Indigenous primary health care, and I guess that's what I wanted to present to you guys today. And thank you for coming, because I know that you've got something to do this evening that's actually quite special. So I'm happy to see that there were some delegates that wanted to come along. So the very first slide that I'm going to show you actually is just a little bit of an outline of what I'm going to talk about. So it's actually, gee, that's hard to see over there, but I'm going to try. I'm going to introduce you to my experience in the health sector and just share a little bit about my journey and actually how I came to be where I am today. I'll give you a little bit of an overview about community-controlled health services, so the health services that I work in currently in Australia, how they started and those sorts of things, and it'll be a pretty quick and as to the point history as I can give you, because it's probably another lecture in itself. The state of play. I'd like everybody to know what we're talking about when we're talking about closing the gap. You know, it becomes a little cliche sometimes, and it becomes something, just, I guess, it's something that shouldn't be cheapened by the media or anyone else. It's actually something that's pretty dear to my heart. I've been working in this industry for a very long time, and it's closing the gap that we've been trying to do for a very long time now. Also want to share with you what we're doing in the southeast. That's a little different to what we were doing probably 20, 30 years ago. So we've gone through some pretty strong reform. And how do we add value to our region? So I'm going to be talking specifically about the southeast corner and the Indigenous populations of that area, which is my traditional land. And of course I'm going to share with you some learnings because I think that's important. You know, as nurses working in this industry, some of the speakers that I heard this morning, it's a pretty thankless job out there in practice nurse land. And we struggle sometimes to find our spot, especially when you've got to forge those relationships between yourselves and doctors. And as you'll see, in my sector there's even more involved because we work in the Aboriginal primary health care sector, which is a very multidisciplinary sector. So when we get to that bit, we'll figure it out. So an introduction to me, all about me at the moment. Aboriginal primary health care is where I started. I started as a very young and very impressionable person, but I thought I was a mum at 20 years old and I thought to myself, well, I better get a real job. So I better go and become a health worker because that's what was on offer at the time. So I started as an Aboriginal and Torres Strait Islander health worker. I worked in an urban setting. Absolutely loved the job. It grew on me and I stayed in that for a good 8 years. It really grew me up, I guess. It made me learn about how to engage with my community. It's one thing to say that you're an Aboriginal and Torres Strait Islander person, but it's another thing to actually engage with your community. I can stand up here with my lovely black skin and my black face and say that I'm Aboriginal and Torres Strait Islander, but it's another thing to actually become engaged in your community, know exactly what your community needs and wants, and then try to deliver that. You learn about strategies and how to speak to people because one of the things, you know, the big part of the business that you're in when you're in Aboriginal primary health care is about behaviour change. You're actually trying to change people's behaviours, people's habits, things that have been there historically, things that have been there for 20 odd years. I've smoked forever, love, what are you trying to tell me to stop for? You know, those sorts of things. And you've got to try to come to that conversation first in a respectful manner because I'm usually speaking to my elders when I'm speaking about things like that. And secondly, you know, from a nurse's point of view, from a primary health care point of view, from a promotional point of view, you are worried about their health. You do want to add a little bit to helping them quit, cease smoking, lots of other things around the lifestyle factors that we have to deal with. So I did learn about how to be an agent of change for better health outcomes for my people. And I also learned the true meaning of holistic multidisciplinary care in the primary health care sector. Now I learned all these things probably obliviously when I first started in primary health care. I was very young. But I did, you know, you do grasp some of those basic tenets of the preventative, the early intervention, the education, the front end stuff, the stuff that you've got to be doing before someone gets really sick and is laying in front of you in a bed in a hospital. So took that experience of 8 years. I decided to go a little bit further after that 8-year experience, and purely because I think I was looking for something extra, and at that time the Aboriginal health worker profession wasn't really offering much in terms of advancement in that particular profession. We weren't to the point of having courses yet, we weren't even a profession in Queensland. So the middle part, and I call it my mid-career because we'll talk about life expectancy and things like that soon for me, which is a bit scary for me, but I'm not going to let that happen. Acute care in hospitals, I became a registered nurse, and I have been a registered nurse now for about 12 years, but I never forget my roots. My registered nursing I chose to do in a rural and remote setting. The city hospitals didn't really do it for me, so I thought to myself, oh, no, I don't think I'll practice there. I do want to spread my wings a little, and I would like to bring my children up in the country. So I decided to move to Mount Isa, and 12 years down the track I really didn't want to move back to the city, but I sort of had to. Out there I learned a little bit more advanced clinical skill, of course, as you do, because in the bush you just have to make do. You make do with what you have and the people that you have on the ground, so you get chucked into all sorts of situations, which was good. Medical models of care, I started to understand what that was as opposed to primary health care, because they're very, very different and very, very different approaches, and also my people have a very different approach to actually the uptake of either or. Learned about care planning, of course, more in-depth knowledge about the patient experience. That was something that was a little bit dear to my heart. I really did want to know exactly how Aboriginal and Torres Strait Islander people experienced care, understood care, and I hate the word compliant. I really, really hate the word compliant, but that's what they use in hospitals. How they became compliant with care, or how the care wasn't compliant with them was probably more the point. I also learned very, very quickly the importance of good discharge planning and how that assists hospital avoidance at the end of the day, and how a good nurse with a good toolkit in a hospital can actually make a huge difference for someone in terms of the follow-up care that they receive, how they get linked to a GP service, and then how the GP service actually uses the information to better the outcomes for that person. Oh, am I going? There we go. Sorry, I didn't press it hard enough. So my current contribution, where I am right now, I work for an organisation called the Institute for Urban Indigenous Health. It sounds like, well, when I first heard it, I thought it was, you know, they referred to it as the Institute. It sort of sounds, I just went, okay. But it's exactly what it is. It's not an institute, but it's about urban Indigenous health. Who we are, we're a regional body and we're situated in Brisbane, in the southeast corner of Queensland. And we were formed by our Aboriginal community-controlled health services within that region. So there are 4 major Aboriginal community-controlled health services. We've taken our organisations in a very short space of time. We were formed in 2009 and we were formed by them, for them, to act as a regional body so that it was like strength in numbers. What we were doing, the 4 Aboriginal medical services in the southeast corner were competing against each other. For 1, funding. For 2, the same mob of patients. You know, it's all the same. The Aboriginal people in the southeast corner are all the same people. So it was more about a strategic response to actually what was needed. What was needed was a concerted effort, not a competitive effort, if you like. So the Institute was formed to be able to elicit that sort of change in thinking, change in the way that we do things. So part of my role is change management for the health services, and we've done a fair bit of reform over the last 3 years, and that's how long I've worked for them so far. And practical solutions in this sector. So we wanted to modernise and improve service delivery through a revamped model of primary health care and business modelling as well, because the other thing that our AMSs rely on is government funds, and we all know, and we're all very presently aware, that this government is no one that you should be relying on. So in terms of, you know, funding, that's what I mean. You know, I shouldn't say that, should I? I sound very political, but I'm not. But it's more about the service that we provide to the people. We want to make sure that that's preserved, and we want to be able to do that into perpetuity. So what do we have to do? We have to become sustainable. So yes, care's first, but we also have to have the backing of a good business model to be able to do what we need to do to provide the care. So the Institute came with that sort of, not intelligence, but I guess, you know, rallied the troops and was able to put the intelligence together, and then we were able to do the concerted work that we had to do as a group in the southeast corner. For those of you that don't know about Aboriginal community-controlled health services, I thought I'd just give you a little bit of a quick and dirty background, bit of a history. So Aboriginal community-controlled health services and the structure of them, they're usually situated where Aboriginal and Torres Strait Islander people are, so where the population is. That's usually where we build Aboriginal medical services, because it's about the access thing, as Lucy so eloquently put in hers. Like, why don't you put the hospitals where the people are, so it's easier for people to get to? Same thing with us. We talk about putting our services so that people can get to them, because not everyone can access public transport, or not everyone has a car. It doesn't matter that you live in an urban setting. Sometimes you just can't utilise those things. They're governed by a community board, and the community board are usually made up of community-based directors, so community people with some governance training behind them. But the most recent addition to the governance part of it, and it's all part of the service delivery, you have to have good governance structures to be able to run these places properly. So expert directors are also on those. So it's now one of the reforms that we've gone through is about Aboriginal and Torres Strait Islander people and non-Aboriginal and Torres Strait Islander people sitting on these community boards that are able to make decisions, strategic decisions on behalf of the Aboriginal medical services in a professional manner, which is a really good thing. Not that it wasn't done before, but the expertise was missing. That's what was missing. It was run on pure emotion, raw energy and emotion. We're a not-for-profit organisation, and of course, like I was saying before, we attract that core government funding. So we have some government funding, but our services also have the ability to bulk bill. So we do run like a GP practice. Press it hard. So the history of Aboriginal community-controlled medical services, the first one was formed in 1971 right here in Sydney in Redfern. And it was the result of the Aboriginal movement in the 1960s, the activism, which led to the advancement of Aboriginal and Torres Strait Islander people in Australia. So it was about us doing stuff for ourselves. We didn't want to be under the government thumb anymore. We didn't want to be put onto missions. We didn't want to be dictated to in terms of where we could go to get health, where we could go to get legal advice. All of that was dictated to us for a very, very long time. The 60s saw the end of that. Well, not the end of it totally, but it actually saw an Aboriginal movement that started things. And this is where our legal services started to pop up. This is where our Aboriginal medical services started to come from. So people started to take their own health in their own hands and their own destinies into their own hands, which was, and it still happens today. 60s, that wasn't long ago. So Aboriginal community-controlled health services served a purpose to deliver the appropriate health care for Aboriginal and Torres Strait Islander people. People weren't accessing hospitals in the way that they needed to. They weren't accessing GP services in the way that they needed to. And the Aboriginal community-controlled sector actually offers what's needed in terms of your chronic disease care, that primary health care, the actual culturally appropriate care that's needed for people so that they feel comfortable to access stuff. So I just saw out in your exhibitors, there is the Clinical InfoNet, Indigenous InfoNet. That's a branch of the Health InfoNet as well, so it's the same organisation. So they've got a Health InfoNet that will give you some of the history if you want to look a little bit more into that sort of stuff around, timelines. It'll show you timelines, different acts that the government put on Aboriginal and Torres Strait Islander people, so it restricted them, freed them, whatever you like to call it. I'm not going to go into that because, like I said, it's another lecture in itself. Oh, No, I didn't think I skipped one. The state of play and how serious is it? So I thought for us, because we're nurses and we're working in the health sector, I would only just put up the life expectancy. There is Indigenous disadvantage across housing, education, all of it. And when we talk about that, it's the Council of Australian Governments that have come together to be able to look at those gaps and start to close the gaps in all those respective areas. But the one that speaks the most to me, because I think very, very much about my family when I think about this, about the life expectancy. Now that's an improvement. That's an improvement over the last probably 10 years. So Aboriginal women, 72.9 years. Aboriginal men, 67.2 years. We've got a 10 to 11 year gap still to catch up to the non-Indigenous population in our country. And that has a big ramification. If you think about that in terms of our culture is an oral culture, it's an oral tradition, it's something that's passed down from elders to younger people. We don't have any elders left, we don't have a culture, and that's the biggest ramification for our people. So you've got, lots of people always ask me, well, why don't they do this? Why don't your people do this? Why don't your people do that? Well, they would if we had the people to be able to teach them. They're very few and far between. I'm not going to say that everybody's dying at that age because there are some people that are living longer, which is great, and I love to see grey-haired old Aboriginal people walking around. It's excellent. But that's not always the case in some communities, and some communities lose their old people very, very young. So therefore their younger generations are walking around lost. And we've got, and the ramifications are huge in terms of how they learn, how they then contribute to society, how they look after themselves, how they look after their future families. It's something that we have to cope with. It's the state of play at the moment, but it's a very, it's something that we've just got to continue on and just get on with. I was talking to a cab driver on the way here actually, and we were talking about, he was from India, so he was talking about some of the things that happen over there, and the one thing I liked about the Indian spirit was no matter where they were in time, it was just, well, let's get on with it. And that's how our communities think. It's not the way we're portrayed in the media, but it is how our communities think. Well, you know what, this is where we are, but we just have to get on with it. I thought I'd put up there a prevalence of diabetes, because diabetes is the easiest bit of information that you can probably grab, and it was the easiest one for me, seeing I'm a little bit technologically disadvantaged. But if you look at the prevalence of diabetes, now diabetes is the root of all evil, if you ask me, in my community. It leads to so many different comorbidities, and it leads to the early death. So if you have a look at the proportion or the percentage of Indigenous and non-Indigenous people reporting diabetes as a long-term health condition by age group, and this is between 2004 2005, so not too long ago, you can see that our population is reporting diabetes at a much younger age. The type 2 diabetes is what I'm talking about here. And if these things go unmanaged, we all know what happens after that. Like I said, I'm going to bring it back to where I'm working at the moment, and that's in the southeast corner. Now, the relevance of this slide, I guess, I wanted to show the population, because one of the things that we battle against in the urban space is the number of Aboriginal and Torres Strait Islander people living in here as proportionate to the population of Aboriginal and Torres Strait Islander people across Australia. Everybody, including, not everybody, I'm just going to say the governments, because the funding for Aboriginal and Torres Strait Islander services usually cruises out to the remote rural areas, which is fine because it's needed out there. That's where I was working. I know it's needed out there. But the populations, the actual concentration of Aboriginal people and where they live is actually in the urban settings. New South Wales alone has the highest population of Aboriginal and Torres Strait Islander people in Australia. Queensland's second to that, in over 200,000 people living in urban settings in New South Wales as well as Queensland. In the Moreton Bay region, we're experiencing a huge amount of growth. So Moreton Bay is probably where it's the clinics I look after. So Moreton Bay is north of the Brisbane River, if you know where that is. It's heading up towards the Sunshine Coast. So we've got, and this was the intelligence that we did in terms of where are we going to put Aboriginal medical services on that side, because in Brisbane the history of Aboriginal medical services is they've always been south of the river, and the people up north have never had medical services. They used to have to travel all the way into Wollongabba, which if you're living on the sunny coast is about a 2-hour drive sometimes. Or if you're on the train it's even longer. So we thought, well, there's a pretty good population of Aboriginal and Torres Strait Islander people in Moreton Bay. How about we build a service out there? So we did. We put a service in Morayfield, which is near Caboolture, which is near the Sunshine Coast, in 2011 to be able to service the population. We've now sprawled out to 3, and I'll show you a slide in a second of how we've expanded. But it just shows in the southeast corner we've got over 40,000 people living there. And the population growth since 2006, that's what it's been in terms of percentage of people to the area. And over the next 20 years, I think they've done some research to say that it's going to balloon even further because everybody wants to live in Brisbane. Because I'm not going to say it because we didn't win on Wednesday night. And I didn't want to come to Sydney because of it, but I'm here. So that's IURH. IURH sit in the middle, and the other 4 circles that you see are our Aboriginal medical services. So I just wanted to make it pretty clear that we've got the place pretty much covered in terms of where these services are. So ACCHSs Brisbane is located in Wollongabba, which is in inner city. You've got Kalwin on the Gold Coast. Everyone knows where the Gold Coast is. The Camboo is out west in the Ipswich region, which is western side of the southeast corner. IURH Moreton ACCHSs, that's where I'm from. That's up north on the north side of the river going towards the Sunshine Coast. And Ulubaribar is at Stradbroke Island. So it's on the Stradbroke Bayside areas. So we've got, those are the 4 main ones. They're the 4 Aboriginal medical services, Aboriginal community controlled services that formed the Institute to be a regional body. They were the only 4 about 20 years ago. In terms of where our populations have grown and spread, we've been able to build the others. We've been able to build all of those medical services in and around Brisbane, which I think is a great feat because it starts to put, it's true primary health care. You're taking the health to the people. So what are we doing that's different in the southeast? Like I said, we've embarked on some service reform since 2009, since the Institute was formed. And we've met the community need and the growing population, as per the slide before. You know, we're building more clinics as we go. And the reason why we can build more clinics, I'll show you in a second. We provide the comprehensive care that Aboriginal and Torres Strait Islander people are needing to be able to complete chronic disease cycles of care, which I'll show you soon. And we're achieving sustainable services through good business modelling. So we're backing up the comprehensive care stuff with making sure that we can start to become a self-sustainable service, less reliant on government. That's what we want to be, less reliant on government. We recognise that our service to our community must be different. So from different, and what I mean by that is, it's got to be different to what we did before. 20 years ago, we did service delivery because we had the resources we had then, we had the people we had then, very scarce on the ground, and we just had to cope with what we had then in terms of what the government could give us and how we could deliver service. We've evolved since then. When the Institute came into play, we started to re-look at the way we were delivering service, and we wanted to smarten it up a little bit because we did have the resources available. We were attracting the people to the sector, so we needed to do something that was a little bit different. So we started from the top and we started from the bottom, and we met in the middle somewhere in terms of reform for our services. It was about the boards, it was about the CEOs, but it was also about everybody else in between and everybody else that was delivering that frontline service as well. We had been passive in the delivery of service for many years, and this had become ineffective. We'd seen that this had become ineffective over the years, and we needed to shake it up a little. We needed to make it a little bit different. Our patients were voting with their feet. We were losing Aboriginal and Torres Strait Islander people from Aboriginal and Torres Strait Islander medical services, which isn't a good thing because we couldn't find any evidence that they were getting the care from anywhere else. But what we could see was an ever-widening gap. So we knew that there was something that we had to do in the middle different. So we acknowledged that our services needed to be less reliant on government, like I was saying before, and we needed to be proactive. So we needed to put in the measures that were going to maximise the MBS for us, but we were also going to provide that comprehensive care in a quality way. I don't know if you can see that. Can you see that? Yeah? Yeah? So that's a comprehensive care cycle for Aboriginal and Torres Strait Islander people through the MBS. This is what we're implementing across all of our services in South East Queensland, and our aim is to get it 100% right for everyone that walks through that door. It starts from the Aboriginal Torres Strait Islander health check, the 715. It goes through to the allied health, 5 allied health visits that someone's eligible for after the 715, regardless of whether they have a chronic disease. Because they're Aboriginal Torres Strait Islander people, we have to get the risk factors. We've got to get to the risk factors first. We've got to do some early intervention. There's also nurse follow-up items there. If they've got a chronic disease that's already recognised or newly diagnosed, then opens up a whole other care cycle, and you guys know that one. That's, you know, people getting billed 721, 723s, or your GP management plans. And then it goes down from there. But our goal is to get that 100% right for Aboriginal and Torres Strait Islander people. The nice kicker to that is that the federal government actually recognised that that very first Aboriginal Torres Strait Islander health check is a very real part of our journey. It's a really good starter in terms of trying to recognise and get that comprehensive picture about what a person's care cycle is going to be like for the next 12 months. It recognises those risk factors. It starts to talk about the social health, the mental health, you know, all of the stuff that surrounds someone, that holistic health care, that is primary health care. So this is what we're trying to do in the southeast corner. We're not getting it 100% right yet, but we're nearly there. Because we've been successful to a degree with implementing this comprehensive care cycle, and it's nothing new, everybody knows this stuff. The only thing that might be new to a few of you is the fact that we put a 715 at the beginning. And that's across the lifespan, that's from cradle to grave. You know, we can bill a 715 as long as we do the relevant health check that goes along with the particular age group. Because we've done this and we're capitalising and maximising what's available in Medicare for Aboriginal and Torres Strait Islander people, we can actually put the money that we're making from Medicare back into our services. We can start to afford the allied health. We can start to afford the specialists. And we can start to afford those Aboriginal health workers that are a luxury to have. They really are, and they're very valuable to the cycle. We can afford the good practice nurses, you know. We've got space for everybody because we can afford this sort of stuff. And this has happened in a very, very short time in the southeast, and we're actually showing some gains here. So the service reform explained, and I've just kept it pretty simple because I could have put up about 10 points, but I don't like too many words on a slide either. So maximising Indigenous access to chronic disease cycles of care, that's what we're about in the southeast corner, that's what we're trying to do. Active community engagement has been one of the bigger things. Now, living in an urban space, people do have access to mobile phones. They do have access to Facebook. They do, you know, the social media stuff. They do respond to those sorts of things. Our community is very responsive and used to be, 20 years ago, to what we used to call, well, down here they call it the Koori grapevine. Up north we call it the Murray grapevine. So it's word of mouth, you know. We talk to each other. We talk about what our services provide, and that's how word of mouth, you know, that's how the news gets around. However, with the growth that we saw before, not everybody is connected with that Murray grapevine locally. So you've got to start to do some concerted effort around community engagement. And you've got to hit the population. You've got to know where the population is, and you've got to hit the population with the information. Because your service is no good if people don't know about it. They're just going to continue to do what they do, and they're going to continue to fall through the gaps, and that's what we don't want to happen. We implemented the comprehensive health assessment, so that's your Aboriginal and Torres Strait Islander health assessment, your 715 billing item. We encourage care planning for those with chronic disease, and we ensure the follow-up care and monitor outcomes of completed cycles of care. We make sure we monitor. The other thing is it's not just about money. We do have a quality cycle that actually follows this through to make sure that we are providing the comprehensive care that we're saying we're providing. It's no good standing up there and saying it. Our community will call us on it straight away if they're not seeing good outcomes. You know, if Uncle's going down there and getting his leg chopped, even though he's been billed all these things, well, what are you mob doing? That's usually what they're saying to us, but they're not saying that to us anymore because we've put some quality systems behind that to make sure that we're keeping that in check and we are measuring what we're doing. And we also value our workforce. We know that we're very lucky to be able to have a GP, nurses to complement the GP, an Aboriginal health worker that can do some of your follow-up care in community. We also have the luxury at the moment, because we can afford to have the luxury at the moment, because of the work that we're doing around maximising the Medicare, of having drivers to be able to go and pick people up to bring them into the clinics if it's hard, if the access is still difficult. So we make sure that we value each and every one of them, and we make sure that we know each and every one's scope so that there's role delineation. And I was listening to someone speak today, and that was a very, I guess, a complex area when you're a practice nurse in a GP practice. What's your scope? How, you know, what are you doing that's any different to what the doctor's doing, and does the doctor really need us in the middle? And all this sort of conversation was happening today, and it was a good conversation to have, but I was sitting there thinking to myself, well, we've actually done that. We've actually delineated the roles. We know exactly what our nurses do in our clinics as opposed to our Aboriginal health workers and our GPs. And everybody knows what their piece of the pie is, and everything fits together to be able to make it work. Oh, there's my green thing. The one thing that we do know, Aboriginal and Torres Strait Islander people value good customer service and a good product. Why do I go to the same coffee shop every morning? Because I like the coffee and the people are nice. It's the same scenario in our Aboriginal medical services. Somewhere along that way over the last 40 years, we lost our way a little bit, and the customer service went a little bit downhill. We're picking that back up. People are coming back. They are voting with their feet, and they are coming back to our services. We know that not all Aboriginal and Torres Strait Islander people will use Aboriginal community-controlled health services. They live in urban settings. They've got other GP services. You know, Nan went to Dr. Smith. I'm going to go to Dr. Smith. That's great. Choice is a good thing. Aboriginal and Torres Strait Islander people will use more than one GP service. I don't know about you guys, but there's no way I'm going to go to any of the GPs that work in my services for any of my women's business. They know me too well. I'm not going there, so I have 2 GPs. I think everybody does. Aboriginal health assessment is not routinely often in mainstream GP services, and we found that as a true fact. We looked at Medicare data before we actually built our medical services and had a look to see who'd billed 715s over a period. You had 8,500 Aboriginal and Torres Strait Islander people living in Moreton Bay, and I think we calculated 14 Aboriginal and Torres Strait Islander health checks across that sparse area, which I thought was a little bit, especially when they actually can give you a pretty good return if you want to look at the dollar value alone. What do we add to the region? The region how do we add value to our region? So we ensure that Indigenous people are provided comprehensive care, and we work to establish relationships with mainstream GPs. We do this because we know Aboriginal and Torres Strait Islander people don't always want to come to us. So we make sure that we provide educational opportunities to educate with mainstream general practices that are in and around our service. When we first started it, I made a point of going around and finding out where our Aboriginal people were going and offering to have nurse exchanges happening. And that was just because I wanted to. That was just because I thought that we had something to be able to share with the mainstream general practice, because there was one, you know, you go to your Medicare local get-togethers, and there were practice nurses who wanted to know, well, we do 715s, but they take us so long. They take, and my part takes this long and the doctor's part takes this long and the patient's walking out in 2 hours. It's just too long. So in terms of efficiency, we've got our Aboriginal health checks down with nurse input and doctor input to 40 minutes, 20 minutes each. So we provided some sort of an exchange and education opportunity there. But we also asked for a little bit in exchange because our medical receptionists aren't as good as some of the mainstream medical receptionists, or not as good, but needed more skilling. So they did the same for us. And it was a really nice exchange and the relationship still exists today. The other thing we offered was cultural awareness. That was the other stuff. That was just opportunistic. It wasn't anything that was structured. It was just, could you come and have a talk to our doctors? Because we do have a fair few Aboriginal people coming in and the doctors want to learn a little bit more and something that's a little bit more practical. So we put our hands up to do that sort of stuff. It's just the extra mile that you take because it's about the patient at the end of the day. It's not about who owns the patient, it's about the patient at the end of the day and just want to make sure people are getting the proper service. And I just talked about that one. So some of the learnings, and I'll leave you with these today. Closing the gap in Indigenous health inequality is everyone's business. So what I'd encourage you all to do today is look for opportunities to share the load, providing the patient consents, of course, because not everybody wants an Aboriginal medical service involved. However, we can offer things like cultural awareness to your staff. You just have to ask. Balance between quality, comprehensive care and good business modelling, that's the other thing that was a really big learning for us. It was always only about care and we always just relied on the government to be able to give us our operating costs. The other big learning was, what we can actually make what we do viable here and we can be less reliant on government, which is what we wanted to do all along. The other thing that was a really huge learning, and this was a big challenge for me today, is to get up here and share some of the good stories within our sector. Because I think we do some really good stuff and I think that we could share a lot with mainstream general practice as we could learn from you guys in terms of how to do the business that we do. Because at the end of the day it's just about the people and it's about the patients that we're trying to see. Because we have non-Indigenous patients as well. So, not every Aboriginal person's married to an Aboriginal person in Australia. We have lots of mixed families, so we have to, cater for that as well. So I hope I haven't bored you too much. Oh, how can you make a difference? Sorry, I forgot the last one. Identify opportunities, learn and create the partnerships. Understand what you want to know. That's the main important thing. If you want us to help you with something, know what you want to know. But sometimes you don't know what you don't know. So maybe it's just a conversation, and we're open to that. Be conscious in care provision, not unconscious. So be absolutely conscious that everyone that walks through your door is an individual. Like Lucy said, understand the other before you judge it. And reflective practice is very underrated, I think. I was talking to someone earlier and they were reflecting on what they've learned here over the last day or two and what they'll probably learn tomorrow they were reflecting and thinking that, Aboriginal health might be a good option. And I hope she does come. Good on you, Steph. So absolutely reflect on what you do and make sure that it echoes through in your practice. And that's me. Thank you.